This is NEGOTIATEx TV.
Hello and welcome to the NEGOTIATEx podcast. I am your host and co-founder, Nolan Martin. With me today is my good friend, co-host, co-founder, Aram, and also another important guest. But Aram, how are you doing today, sir?
I'm good. How are you, Nolan?
I am doing excellent. Do you want to go ahead and kick off this podcast by introducing our guests?
Sure. Hi, everyone. Great to see you today. Today, we are joined by Andy Prisco, founder of Jumpstart Mastery, a network of public safety professionals, behavioral health professionals, and private enterprises who all share a common interest in reducing episodes of anger, aggression, and violence through shared training, education, and collaboration. Andy is the founder of the Psychiatric Emergency Response Team program within the state of Washington's care and services system. The program structure, advanced training, and people are credited with significant reductions in violence, injuries, and the use of seclusion and restraint in state hospitals, forensic psychiatric facilities, and total confinement facilities. Andy is also a fellow with the National Anger Management Association and a co-developer of the only certification available in crisis intervention from a professional mental health association. He is also the author of the Crisis Intervention Certification Handbook, Best Practices for First Responders. Andy has provided de-escalation training and presentations across the United States and Canada to law enforcement professionals, hostage crisis negotiation teams, fire EMS personnel, behavioral health professionals, and psychiatric nurses. In addition to behavioral health credentials, he maintains public safety credentials as a firefighter, an EMT, fire training instructor, rescue swimmer, rope rescue technician, might have to hear more about that, Andy, and company officer. In 2017, Andy was a nominee for the Hero of the Year Award from the Washington Council of Behavioral Health. He won the prestigious award in 2019. He is the founder of the Omada Arit Thought Group, which is a think tank of cross-discipline global experts revisiting values and first principles in care and service programming. Andy, thank you so much for joining us today.
Yeah, I'm almost embarrassed by the length of my bio, but I'm seeing all the images over the 20 years that represents, and I'm realizing as I'm looking at myself in this software, at my gray beard, and there's been a lot of experiences there, and I thank you so much for your willingness to witness me and my work in this context. I thank you both very much, Nolan and Aram. It's been a long journey, and I've really been kind of not visible to the world in any public way until recently.
And is that a dog we hear, Andy?
It's my wife crashing around. So I apologize, guys.
That's fine. And you can cut that out. No, I got two dogs here with me, so
and I got three with me. So
I'm always aware of the noise that they make. So
yeah.
All right, Andy. Well, let's talk about your professional journey. How did you get to this point? What really brought you into the negotiation space or de-escalation space? I don't know how you want us to refer to it, but definitely excited to hear about the journey of you getting to where you're at today.
Well, I think I think our formative experiences carve and shape the overall orientation of where we find ourselves as human beings, flourishing whenever we do flourish. And we look back and recognize that these things that we went through were so material to what we're doing today. And I would imagine you gentlemen could think of formative experiences in your development that set the stage for you to be doing the work you're doing. For me, and many people who work in the behavioral health space, people who work, I think, in any space where their mission and purpose is from some place of selflessness to reduce suffering elsewhere. I had my own kind of suffering I had to live through and work through um, as a young boy, and in my family system. And without taking too much time and getting into too much detail, I think the jury is back on that now, and I think that nearly everybody that we encounter can recognize the formative experiences when in your family system there is potentially alcoholism, drug use, other forms of influences in the family system that can influence the presentation of a family member or someone else in a way where we might, as human beings growing up, feel unsafe. We might feel particularly, acutely attentive to the environment, and sometimes on occasion have to adjust our own behavior so that other people in the environment are manageable. We grow up very often in settings where people's emotional state can be regulated by who we are in the moment, and if things for them aren't just right, they can explode. So I grew up with a high sensitivity to the emotional arousal of others, I'd say, so that I could get through a day, um, without a problem. And the work I have done in my adult career has been heavily influenced by that sensitivity. My formative experiences in observing someone else's distress and acting and conducting myself in a way so as not to make that worse, and if anything, try to make that better. I think that's what set the stage. And my fascination with psychology, which could probably be credited to a number of things, is what led me to a long, struggling undergraduate career of driving a truck and going to school at night and taking an extraordinary amount of time just to get my undergraduate degree. And then beginning the process of working in a care and services system, which began in, believe it or not, Paterson, New Jersey, a very urban setting where I was working in what's known as a psychosocial rehabilitation model. It was my introduction into care and services was a model of care where there were no staff-only areas, no staff-only bathrooms, no staff-only break rooms, no staff-only offices. There was only one area that was off limits to people served, and that was the medical records room. But that kind of place of equity, if you will, in the delivery of care and services was my initial exposure to the work, and from then on I was hooked. And that was in the late 90s. Yeah.
How did that help lead to? I'd love to know more about the psychiatric emergency response team program that you created in Washington. So how did that experience kind of lead to your creation of the team?
Yeah, so uh, that experience uh, of being in an environment, particularly where the therapeutic structure was one of shared space and shared relationship. Those environments, for all the people who work in them, require those people, when someone presents some kind of discontrol or dysregulation. Care environments don't have use of force policies. We don't use that word in psychiatric care and services. So anyone who presents aggressive and even violent behavior, property destruction or assaultive behavior, until the threat itself becomes imminent, until the fist is cocked, until the chair is proffered over the head, until the golf pencil is in their hand and they want to jam you with it, words are the requirement. There is no preemptive seclusion or restraint. There is no preemptive manual restraint. There's words until the presentation of imminent risk, And even under imminent risk conditions, the spirit and the expectations of the regulations in our world is that we're going to the last moment to give someone an opportunity to engage a capacity for self-control. The psychiatric emergency response team in our state was largely inspired after an event in which I was involved, was the single largest joint metro SWAT response to a psychiatric facility in our state, where, in short, a patient in the forensic care area of the facility, and I'll leave it nameless, attempted to start a fire, successfully started the fire in a locked treatment unit, resulted in evacuation and disruption of daily operations. We had to move this person to a different secure area. The person monitoring the person served in this new area actually fell asleep. That person served plucked the magnetic key card off the sleeping monitor, moved through 2 electromagnetic secured doors to a non-patient care area, barricaded themselves with a knife taped to a crutch from a break room, and then bleach and ammonia and cleaning chemicals at the door and fire load. And his intention was to start another fire and defend himself and from anyone trying to stop him. And without getting too deep into the weeds, in collaboration with the wonderful crisis negotiation personnel from the Joint Metro SWAT unit, I was able to move into position with armed and armored personnel. And while a tactical response was being conceived and produced through the use of words and meaningful de-escalation programmatically that we had developed at the facility, we were able to get the person to cooperate with staff and surrender. And they've since gone through the legal process and gone to prison. This was in a state psychiatric facility. But nonetheless, the demonstration to the hospital at that time was there's nothing worse in a care and services setting for there to be 25 armed people and vehicles outside, and very, very disruptive to the clinical environment. If there was a way that could be prevented, the hospital and the stakeholders in it had, upon seeing the conclusion of this event, entrusted me with the responsibility of developing a program to make sure that never happens again. And that was the basis, that was the formative experience of the team. And the team has since programmatically gone on to be the embodiment of words-only response to high-risk emergency. And this doesn't mean careless response where they're putting themselves in inappropriate risk, but in a psychiatric care and services setting, what the data is in and the jury is back, that we have had our hands on the same people over and over again, secluding and restraining them, and we now know that doesn't modify behavior. It may acquire safety in the moment, but it doesn't modify behavior. It doesn't influence. In fact, it very often just makes things worse. So we have to meet the challenge of the presentation of high-risk behavior differently if we want to change the outcome and reduce the likelihood of future emergency. That's what the psychiatric emergency response team was all about.
Hey, thanks for checking out this video on NEGOTIATEx TV. If you found any value at all, please hit the subscribe button, hit the notification icon if you want to be notified of future videos. And then we also have a couple videos over here that you might be interested in checking out. If you and your small business, your team, are looking to get negotiations or leadership training, then you can head over to NEGOTIATEx.com and learn more about the coaching services we offer. Thanks, and I'll see you over the next video.